Hi everyone, this is Matthew Ravi and I'm back for another video. Today I'll be presenting about a very interesting topic which is known as giant cell tumor. So what is giant cell tumor? So it is also known as osteoclastoma, which is a tumor of the bone by massive destruction of the end part or also known as epiphysis of a long bone. It is benign but at the same time it is a locally aggressive tumor of bone as it can turn malignant, but this is a very rare condition. And it is composed of proliferation of mononuclear cells with scattered macrophages. It is very common between 20 and 45 years of age. So as you can see in the diagram here, this is how the giant cell tumor looks like. It also affects the distal part of the femur, proximal tibia, distal radius, and proximal humerus. And when it affects the spine, it will most commonly arise in the vertebral bodies of the sacrum, and that also with reduced frequency. So when it affects the spine, it would usually occur in the vertebral bodies. So that's in other words. And coming to the clinical features of giant cell tumor, the patients would usually come with pain, swelling, as well as limited joint movement. They will have also an increasing mass, but it is less frequent, and this mass is particularly around the knee. And in a very small number of cases, like 5 to 10%, pathological fracture is the presenting feature of it. And for the investigation part, so usually what you will do is you will take an x-ray of the knee joint, and that would itself will demonstrate an eccentric, expansile, and a lobulated lytic lesion with a narrow zone of transition. So this is how it looks like. The x-ray of giant cell tumor, this is how it looks like. And soft tissue mass would sometimes be covered by a thin layer of sclerosis, and that can be seen on an x-ray as well. At the same time, chest x-ray is also needed to look for lung metastases. As I've said earlier, the it can also proliferate into a malignant type of tumor. Now coming to the staging of giant cell tumor. So giant cell tumors, they are staged according to this classification, which is known as Campanacci's classification. So here there is stage 1, stage 2, and stage 3. So for stage 1, it is completely intraosseous. Stage 2, it demonstrates an erosion of the cortex, but it is without destruction. But stage 3 is the one that is characterized by cortical destruction with a soft tissue component. So stage 3 is the one that is usually the worst type of staging of this giant cell tumor. And coming to the differential diagnosis, there is so a person can able to differentiate make a differential diagnosis based on the type of tumor, and so basically the person can assume that it can be an aneurysmal bone cyst, can also be a non-ossifying fibroma, or it can be a giant cell rich osteosarcoma, which is malignant, chondroblastoma, at the same time metastatic carcinoma, which can metastasize to other parts of the body like the bones and the organs. And for management part is divided into two types. One is conservative management and the other one is surgical management. So just for a brief part of conservative management, so the pros and cons of conservative management is basically uh, it is non-invasive, but at the same time it takes longer time to heal. But surgical management, although it is invasive, but although it's invasive, but it would it would promote some sort of a healing, although it doesn't heal completely, but it would at least promote some sort of a healing. And and that's what we're going to look at. So for conservative management, radiation treatment will be done, and it is indicated for inoperable or multiple recurrent lesions. So there are certain types of tumor which are inoperable, so radiation treatment would be given for it. And medical management, there are drugs being given such as bisphosphonates, which is an osteoclast inhibitors, and it decreases the site of defect in giant cell tumors. Another drug is denosumab, and that would decrease the size of the bone defect in giant cell tumor. And coming to surgical management, so extensive curettage can be done as well as reconstruction with adjuvant treatment. So this challenge of treatment is to remove the lesion, but at the same time to preserve the joint and providing support to subchondral joint. And extensive removal of large cortical window over the lesion is required. So the bone lesion can be filled with a bone cement or an allograft bone. And last but not least, if if none of these management can able to get the patient recovered from this kind of tumor, the last solution is amputation, and and that need to be done with the patient's consent, and is usually indicated for lesions with cortical breakthrough which cannot be altered due to intercalary resection. So what is intercalary? Intercalary is the replacement of the diaphyseal portion of a long bone after the segmental skeleton resection. So that's about the amputation part of it. And that's it. That's about giant cell tumor. It's quite a short topic. And so thank you once again. If you like this video, do like it, give a thumbs up. At the same time, share this video with anyone whom you know, and most importantly, do subscribe to this channel. And I'll see you in the next video. Stay tuned.